Hello and welcome, everybody. I'm Gustavo Tolosa, the host for the McDougall webinars. And this week we have a very special guest that Dr. McDougall is going to introduce to you in just a minute. But first, I want to welcome Dr. McDougall. How are you doing, Dr. McDougall?
Well, I am doing well. I'm having fun, and I'm going to integrate some of my recent activities into our interview with our very important guest. As a matter of fact, this man has changed the world. And he's done it from a position of establishment. I mean, he's a real doctor, well-respected, credentialed, recognized, and so on. And he turned coat on the standard practice of medicine. But we'll get into those deals as to how he changed his position. And it was a crucial thing for our next guest to stand up and say what he believes to be true. And then to spend the next 16 years of his life exposing himself and saying, look, regardless of the fact that I'm a world famous cardiologist, an MD, a practicing doctor who sees patients, and the former head of the American College of Cardiology, regardless of my position, I'm going to tell you what I really think about the practice of cardiology, the nutritional issues, and maybe we'll get into some of the current treatments of cardiology. I'd like to welcome Dr. Kim Williams, MD, well-respected, on a rocket ship trip to stardom in terms of leading the movement towards better health. I'm not going to call it veganism. I'm not going to call it any particular name, except everybody knows what they're supposed to be doing. And Dr. Williams, let's start out with that fateful time in 2003 when you decided, the heck with it. What I'm going to do is I'm going to tell the world that I was not in my best of health, and that I learned some things that are contrary to what's being taught. And I changed my life, and I decided to tell everybody about it. Can we start back in 2003 as to how your life changed and why?
Certainly, Dr. McDougall. And first of all, thank you for having me. It's always enjoyable to talk with you. I learned so much from hanging out. At 2003, actually, I was feeling perfectly fine, and I can live to tell about it. I had sort of moved away from coaching my son, who was a nationally ranked tennis player, so I wasn't playing as he aged out of the junior nationals. And so I wasn't playing tennis twice a day every day. And exercise really does have a effect on your metabolism. That, and I'd gotten a little older. That is, I always like to tell my patients, you'll never be as young as you were when I started this sentence. And so as it turns out, you put those two things together, and working a little more sedentary lifestyle, going into the leadership of the American Society of Nuclear Cardiology, doing a lot of documents and manuscripts. You put those three things together, and all of a sudden, I showed up at my cardiology meeting, American College of Cardiology, in March of 2003, and I did what most of us doctors would do every now and then, and I think I hadn't done it in 2 or 3 years, was to measure my cholesterol. Of course, the cholesterol measurements are done by the lipid lowering drug makers. Okay, so when I got my LDL of 170 in the Lipitor booth, I assumed that Pfizer was just trying to sell me drugs, and it wasn't real. I never had an LDL of 170. That would be fatal if I left it there, and in fairly short order. So I went over to the Merck booth. That's back when simvastatin was actually not generic yet, and so they had a long line there as well. And unfortunately, the LDL came back, and I said, okay, so at this point, it must be that Pfizer and Merck are working together on this. So that I actually did get to see the Nile River. It's as wide as you could imagine. Okay. And I was definitely in denial. So as it turns out, I fasted the rest of the day. And I actually went back to the Crestor booth the next morning, and the LDL was still 169. And so I was very fortunate to have run into the publications by Dean Ornish, introduced by a friend of mine at the Association of Black Cardiologists, Dr. Tazewell Banks. He passed away a few years ago, but he had been a lifestyle guru as the director of the coronary care unit in the DC General Hospital. And he was always telling everyone, and of course, I'll tell you what he says, but then I was always following it up with, Tazewell, you got to publish this. because no one will believe it until it's a peer-reviewed publication, which is going to be a theme for a lot of what you and I talk about, Dr. McDougall. But Tazewell was saying that he had changed, based on Dean Ornish's work, he had changed every patient who came into DC General with a coronary care unit with a heart attack, changed them to a plant-based diet, and he had 0 recurrence of unstable angina or myocardial infarction over the first year. And, that's a startling statement because, we weren't using statins as much as we could have back then. We were just getting to the point where we were deploying stents. And we were never changing people's diet. We were doing sort of called phase 1 cardiac rehab and getting people up and about sooner than they had been, say, a decade earlier when they were, or even 2 decades earlier where you're supposed to be in bed for 6 weeks. We knew better than that. But the uptake of cardiac rehabilitation was poor back then, and it's still very poor. Less than 50% of our patients are actually referred to cardiac rehab. And so we have this lack of thinking about the next event other than antiplatelet drugs and antithrombotic drugs and statins. And all of that, as everyone has always said, who's thought about it, all of that is mopping up the floor. And, we really need to get to the root of the problem and try to deal with that instead of trying to stop people from having an event at the last moment. So anyway, he had been pretty much unsuccessful in convincing those of us at the Association of Black Cardiologists to change the menus at the meetings. But he kept trying. So he was in the back of my mind. I immediately did a search engine and realized that my American Heart Association diet that included fish and chicken, but no red meat, no processed meat, still had a lot of cholesterol. I was lowering my mortality rate, but I was not lowering my cholesterol. And so then the next great fortune for me is that right that week, as I was changing to a plant-based diet, the David Jenkins portfolio diet was published in the Journal of American Medical Association. It's March of 2003. And the timing of that was spectacular for me. I immediately started doing the fiber and the plant sterols. And a few weeks later, I measured my cholesterol again, and my LDL had dropped from 170 down to 90. Now, David Jenkins actually had more like a 30% reduction in LDL cholesterol for the population that he studied. But that is not the upper limit. There are people who are extremely sensitive to ingestion of cholesterol, and I'm one of them. And it's genetically predetermined. If I eat animals, my LDL will be off the charts, and I would develop plaque, heart attack, stroke, peripheral artery disease, and everything that goes along with it. So fortunately,
how has your diet evolved then? That was 16 years ago.
Indeed. So the one thing that has evolved for me. And there's been a lot of evolutions. People say that I'm unique in that I could just take a randomized trial or a prospective large cohort and adopt it immediately, give up what it is that I like, give it up cold turkey. And I say, yeah, without the turkey. And so as it turns out, there has been evolution of my diet as so many insightful things have been published. So I don't do the psyllium that I was doing back in 2003. It is on the portfolio diet. It turns out that lowers, it's really good for lowering triglyceride levels. It does lower LDL. It lowers HDL. And back then we were afraid of lowering HDL. We were doing everything we could to raise HDL. And I was taking niacin. It's a vitamin. It seemed natural. It does. The big side effect of niacin, I just have to admit, is flushing, and patients can't stand it, so many of them. Well, for me, that meant 30 minutes a day I was going to be hotter than normal, which was fine with me. My favorite thing is playing tennis in 106-degree weather, so a little flushing doesn't bother me at all. And as it turns out, 2 very large randomized trials show that the niacin does improve your HDL. It does decrease your LDL a little bit. That ratio improves, and your outcomes do nothing. You do not decrease mortality at all by taking it.
Maybe a few more strokes.
So that's strokes, infection, GI bleeding. And this is another one of the themes that, we may think we know pathophysiology, and we may think we know lipidology and everything that leads up to the cataclysmic amount of cardiovascular disease in the United States and around the world. But until you have prospective randomized trials, you're skating on some thin ice, and that ice can crack. And so I did give up my flushing every day with my medicine because the data was not in support of it. So that was one transition I made, not taking the fiber as much. Probably the next big one, which was, I think, very, very important, was several years later when there was a large, it's a prospective cohort, but they looked at sugar intake. And, those of us who were thinking, if it doesn't have a face and it doesn't have a mother, it's okay, we're a little misguided in that you can take a vegetable product and remove the fiber, for example. Take a fruit and make a juice out of it, and the fiber's gone. And you're going to give yourself something that's going to raise your insulin level. And if you raise that insulin level, you are going to create obesity. You are going to increase the amount of plaque, hypertension, hyperlipidemia. This is all of the bad things that you wouldn't want to have for cardiovascular outcomes. And so the sugar mortality article in 2014 really, and also in the Journal of American Medical Association, I like to call it my vegan propaganda journal. It isn't, obviously. It gives me a lot of insight, but these are peer-reviewed literature articles that may be criticized because the Nurses' Health Study and health professional follow-up, doctors and nurses don't know how to fill out food frequency questionnaires. But I know a lot of doctors and nurses, I think they actually do know how to fill out those questionnaires, so that you take 100,000 people and you can get some really insightful information about what correlates with bad outcomes. And one of them was sugar. And so I openly admitted that Oreos had gone vegan a few years earlier, and I would actually have the package, and I'm staying up till 2:00 in the morning doing inpatient notes, and I finally finished the notes, and I look over, and the whole Oreo package is gone, and I said, "What happened? My notes eat my Oreos," and so that added sugar mortality data really did change the way I thought about nutrition. It isn't just about avoiding cholesterol. There are other factors that we have to take into account. And one of them is sugar intake and things that will increase insulin. If I could wrap them all up in one package, no pun intended, because they're all packaged foods mostly, it would be the things that generate an insulin response. So the quick list would be sugar. It would be any, believe it or not, sugar substitutes. There are only two of them that I'm aware of, and anyone wants to write in and tell me a third, it would be great. Artificial sweeteners that actually do not increase insulin levels. All the ones that people are thinking that they're going to help, despite all the data that says when you change from full soda to diet soda, your weight does not change. That's because the artificial sugar still increases insulin levels. What happens when the insulin level goes up? You increase peptide and glucose absorption and deposition. And so it's great if you're trying to grow something, but most of adult Americans are not needing to grow anymore, okay, if you know what I mean. So what we're asking people to do then is to stay away from the sugar, refined flour, things like white rice, that you would think that white bread, it's got some nutritional value, it's got calories, but it generates an insulin response very similar to just eating pure sugar. And so then if you compare white bread, glucose, fructose, sucrose, you get a very similar reaction. Fructose, the fruit sugar, does give a little bit less. And then you go back to those two things that I mentioned that don't generate insulin. One is this root from South America called yacon. It looks like a sweet potato, but yacon syrup actually does not increase insulin. And there's actually a randomized trial showing the effect of not using a sweetener that doesn't increase insulin results in weight loss. yeah, there's a little problem with the oligosaccharides in there causing a little bit of diarrhea. But if people can put up with that, if you've got to have some sweetener, that's probably one. The other one is erythritol. That generates very little insulin levels. And so you've got a couple of options to avoid this, but people really should be getting away from refined carbohydrates and away from sugar. And people did that. Their insulin manifestations and all of the diseases that are generated by that bumps that we do with every meal in the United States would improve dramatically.
Let me interrupt just to fill in a few things in your conversation. Did they ever get you on statins?
So I actually very briefly took a statin, thinking that there was no way to get my LDL as low as it needed to be. Fortunately, we actually, and that must have been about 2 weeks. And I actually did, and I had no problem taking it. I was taking a low dose of a long-acting, Crestor. I think it was good for me just because the statin data is so strong. Statins are the most, I would think, and I know you have some different opinions about this, but as a
I use statins on my patients.
Oh, you do? Okay. So I was going to say, I know there are a lot of people in the plant-based world who think that statins are unnecessary. And unfortunately, I've seen a fairly large number of people who really needed the statins, didn't take them, and ended up having a bad event, even though they were vegan. And so my good friend, Neil Stone, who has been so helpful in putting out our ACC-AHA guidelines on lipid treatment, his favorite line, if I could use it, it says, you've got lifestyle and you've got statins, and our uptake of both of them are terrible in cardiovascular medicine. And the question is, the way he likes to say it is, which arm do you want me to cut off? And trying to help you. Okay, and so I ended up being able to manage by getting back into tennis myself and much more exercise, being more careful, so I don't feel like I needed the statin. But then along came the pooled cohort equation. If people aren't familiar with that, it's an app that you can get. It's the ACC-AHA risk calculator, and it's based on the so-called pooled cohort equation, where they took these massive amounts of data sets and which tell, okay, if you've got hypertension to this level, as opposed to a lower level, what that does to your risk. So I've got a lot of bad things going on in terms of my risk. That is, I'm African American. That actually almost doubles my risk. I'm a man compared to a woman, age over 60. That is a very large amount of, sounds like it's time to go to church.
No, it's my grandfather clock.
Oh, that's wonderful.
But that gives me a chance to interrupt you a little bit. How much weight did you lose?
So actually, I didn't actually start losing weight until much later. I had been a professional athlete. I hadn't, somebody measured my body fat at 3%. So the kind of weight loss that people get on a vegan diet, that really is dependent on how much body fat you have to lose. There is another thing, and I'll get back to the other pool cohort equation in a moment. The other thing that you worry about as you get older, and I think I'm experiencing it, the more traveling that I do, being very selective, I'm not eating what everybody else is eating at most meetings, because the medical meetings have been terrible. We're starting to have an impact. I've been to 2 meetings now where they had vegan food for the attendees. So we do have an issue of so-called sarcopenia, where if you're vegan and you're getting older, if you're not focusing on exercise, you're basically going to lose muscle mass. And so, comparing my weight now to my playing weight as a professional tennis player, I've really lost about 30 pounds. So I do have to focus on it. I got to maybe a little bit less travel, a few less lectures, and hit the gym and bulk up. And so the next time you see me, you'll see something there.
Well, we've known each other for a decade, and every time I see you, you look younger and handsomer. So something must be working.
Thanks.
A couple final things I wanted to fill in for my interest. One is any medications or supplements that you take at the present time that you feel might be you've already talked about statins, and we agree that there's definitely a place in high-risk patients for statins. Any other medications that you may be recommending to yourself, to your patients, any supplements, et cetera? And then what I want to ask is, what do you eat? What do you eat these days?
So this is very interesting questions, all. Let me do them in order. In terms of statins, what I was going to mention about the pool cohort equation that came out in 2013 is that it told us that not as many people as we think need a statin. And despite my age, gender, African American ethnicity, I come out below the level, even with an LDL around 89 or 92. My triglycerides are almost my shoe size because nobody's got it. And when you put all that together, it turns out that my pool cohort risk is less than 7.5%, which means that I actually don't need a statin, according to the ACC-AHA. And when that came out, so many of my patients were shocked when they came back and I said, yeah, well, you've had a high cholesterol. You're doing what you can with lifestyle. And because your blood pressure, like mine, when I went vegan, my blood pressure dropped. It's still 104 systolic. That drives that risk down so much. I'm taking you off your statin. And so, and let's see how it goes. So I would recommend that. It's a great party tool. You can download it for free for your phone. ACC-AHA risk calculator tells you your 10-year and your lifetime risk. You know, you get it, you're sitting at a party and you say, okay, what's your cholesterol? What was your last blood pressure? And you plug it all in and say, you're 22.5%. You better go see your doctor on Monday. And so it is kind of fun to play with, but it also is a great management tool. Okay, so other than that, the next question was really about supplements.
Supplements. Is there a place in your program, personally or professionally, where you think supplements do more good than harm?
I would mention 5 things. 4 of them based on relatively small randomized trials. They would be since we're on this subject of cholesterol management, in addition to making sure that someone is doing the required amount of exercise, plant-based nutrition, a high fiber diet. There are 4 things that are relatively recently published that can lower cholesterol. One of them is Indian gooseberry. That's called amla. Another one is berberine. Another one is my favorite tea, but it's more than what you do with the tea. That's Earl Grey, because that flower that they put in it, bergamot, actually has a randomized trial for lowering cholesterol. And last but not least, Brazil nuts. Now, I have to admit that having tried these, some of them myself, some of them on patients, recommending people who absolutely don't want a statin, always warning them, hey, niacin improves the lipids, but did not improve outcomes. So when you have a biochemical trial, even though it's randomized and prospective, if you don't have outcomes, you're, again, skating on a little bit of thin ice. And so you might be ending up eating a whole lot of Brazil nuts, improving your numbers and not improving your outcomes. So I always warn them that, but I'm reserving these for the patients who say, I'm absolutely not taking a statin no matter what you tell me. And so, then you start doing all these other things. The last one to mention that's gotten more of a profile recently is the whole B12. I bet most people in your audience, Dr. McDougall, understand this already, but for the couple who may not have heard it, it's worth just going over that, people are saying, well, I'm going to drink milk and eat, cow meat or whatever to make sure I have enough B12 because vegetarians get B12 deficient. Well, cows don't make B12. Mammals don't make B12. It's made by bacteria in the soil. The reason it's in a cow is because a cow eats dirt. They don't wash all the grass off before they eat it. Humans tend to get rid of the dirt, and therefore, you've really only got a few options. One would be to eat an animal, which is basically going to kill you, at some point prematurely. Number 2 would be to eat dirt. This may not be all that palatable. Number 3 would actually be to take a B12 supplement. And so most people who are doing plant-based nutrition are taking a B12 supplement. They've heard about this, but what they may not have heard about is the large, again, observational, but the observations in a huge amount of people showing that if you're taking too much B12, very similar to the vitamin A trials about 15 years ago. There's a population that's at risk. They are men over 60 who were ex-smokers. If you fit that profile, you must get your B12 level that you're taking to an average of less than 55 micrograms per day. That's not easy because those pills come in 500s, they come in 1,000. A patient who's in my office yesterday with a 5,000 microgram pill, how do you divide that up and get 55 micrograms per day? Fortunately, it is stored pretty well if you have normal B12 metabolism and absorption. And so you should be able to take one of those 500s, chop it up in pieces and take, a little piece once a week or something like that. Unless you're not a male, unless you're not an ex-smoker, or you're not over 60. And then it probably doesn't matter because most of it's going to go in the urine. And they say that when you're on the topic of supplements, that the United States population has the most expensive urine in the world. Because
let me take you off in another direction. I know part of your training was at Wayne State University. I'm from Detroit. Mm-hmm. And back then, there used to be clouds in Michigan. And you're a darker skinned person. How about have you fallen into the vitamin D trap? Or are you trying to get sunshine?
So I fortunately for me, I don't do much in terms of vacation, but I do tennis. And so I always go to the Australian Open and in Melbourne in the middle of end of January. And I will play tennis outdoors and sit in the sun baking for 2 weeks. And I'm hoping, I have never measured the level, but will that last for 52 weeks? But, I do try to get to other events here and there, but there's nothing like that amount that I get. And so you're absolutely right. It's a problem. But as you mentioned, falling into the vitamin D trap that most cardiologists were in on preliminary data that really was not prospective. This is another great example. We thought that vitamin D deficiency was responsible for hypertension, dyslipidemia, that it was resulting in heart attack, stroke, and death. It turns out prospective randomized supplementation trials show that it's really none of the above. So I don't want to be the expert on bone health, and all I know is that when you do plant-based nutrition, your bones are better off, and it may be that your brain is better off and you're not falling as much, but that risk of fracture with dairy may have a variety of mechanisms that have nothing to do with vitamin D. But I would say that that in cardiology, it's been very disappointing, and so we're not recommending vitamin D right now.
All right. I'm going to save the question as to what you personally eat till later on, because I'm going to get into a couple other issues. One thing I want to know is what's been the reaction over the last 16 years? I mean, you're not a shy violet sitting on a shelf. I mean, you're a really outspoken person. And as a matter of fact, you shared with me prior to our interview here that you've gotten a little frustrated over the years, seeing the obvious and it being ignored by our colleagues.
Right.
So tell me, how have things been over the last 60 years, being such a renegade, being so outspoken, and we're going to get into some of the current cardiac business in a minute, but just the fact that you are a vegetarian, vegan type doctor who thinks that this is as important, if not more important, than the pharmacologic and the surgical side of the business.
Yep. Yes. So let me talk about that. I was not a shrinking violet. I would talk to anyone who mentioned it, and I would talk to my patients. And all my colleagues knew. And when I was at University of Chicago, there was one trainee who was so wonderful that I hired her twice at Wayne State and at Rush. And she was in my clinic for an entire year, and every Wednesday we had this argument about nutrition. She was from the continent of Africa and said her family had great longevity and ate meat every day, and that she would never give up meat. It's so funny that now there's enough data to convince even the skeptic, but back then it was tough. And so and just using my own personal cholesterol was really not that large database that we really have now. And so I wasn't really talking about it, Dr. McDougall, until I was elected to become part of the leadership of the American College of Cardiology. As incoming vice president, I was at one of the meetings, and We're talking about advocacy and trying to get healthcare delivered, and all the things that we do. And I was asking for plant-based meals. And one of the media people picked up on it and says, "So why are you doing that?" I said, "Oh, heart attack, stroke, and death. Other than that, no reason." And her response, and I would love to catch up with her someday to realize what she did to me. Her response was, "Well, we should put that in the ACC blog." And I don't know who reads the ACC blog. A lot of times at big organizations, you send out an email and the opening rate is somewhere around 16% if you're lucky. But that blog about my dietary approach and Ornish portfolio diet was actually picked up by MedPage Today.
Yes.
And once it was picked up by MedPage Today, it was picked up by the New York Times. And then all of a sudden, I'm in the soup, and people want me to be a spokesperson and things like that. I had been very silent. And then the data started coming in, seriously. So putting together lectures, I never delete a slide. So I very much frustrate the people who they say, I've got to have your slides ahead of time. Well, there's 212 slides. I'm not going to show them all, but all the data is in that talk, and I collect them all. We've had incredibly great publications that I try to make sure that everyone has seen about healthy nutrition, about unhealthy plant-based diets with all the refined flours and oils and all the things that we've talked about before, juices, for example. All of that data, I do go around, and I think people are resonating with it. And there's always something in the literature that they A, haven't seen, and B, aren't doing. Okay.
Well, let's talk.
Right. And so your question about how has it been received? I did at one meeting say, very secretly a quip that I had quoted to myself and close friends, but no one else. I had said that, the two kinds of cardiologists, vegans, and those who haven't read the data. Of course, I, A, was joking, and B, I was really talking about the fact that we needed more trials to be published in cardiology literature. Publishing something in the American Journal of Clinical Nutrition is great. I'm going to see it, but my cardiology colleagues are not going to see it. And so that's really what I was talking about. But of course, that was interpreted as me throwing every cardiologist under the bus. And of course, the people who work for me at Rush, a lot of them saw that, and they looked at the data, and I have the largest collection of plant-based cardiologists of any university, I'm sure. There's probably 20 of us, some graduating and coming and going, but there's a lot of plant-based nutrition at Rush now because of that insane statement that was totally misinterpreted. But that sort of put me, now there are memes and coffee cups and all these things that people are quoting that and a few other things that I've said. But what I really would like to say is that the frustration is trying to change the medical systems and to make sure that we have plant-based meals available at meetings. Why? Because we are in the business of improving the heart health. That is actually the American College of Cardiology mission. Transform cardiovascular care and improve heart health. And why wouldn't that start with nutrition, since that's at the basis of pretty much everything that goes on in the cardiovascular space? And so people are recognizing it. Our CEO is someone who's helping us try to deliver that message. And so I think we have had some movement. I'd like to see it happen all of a sudden. Why? Because I tell you, Dr. McDougall, my biggest frustration is getting referral after a person's been in the hospital and they have had a stent or they've had bypass surgery. And I say, and what did they tell you about nutrition? And the answer always comes back, nothing. And the same thing that put them in that situation is going to do it again. And so I go through with the patient, if you have a minute, I'm shocked at this. I started doing this in January, not even sure why, but it came to me. I started just walk the patient through the process. So I say, okay, I'm just going to quiz you a little bit here about what your understanding is about why you're here in this coronary care unit. What actually happened to you? And the patient will say, well, I had a heart attack. You should know this, doctor. You're coming. I said, yes, okay. But why is it that you had a heart attack? Well, because I had a blocked artery and they opened it with a stent. Aren't you reading my chart? I said, yes, yes, yes. Okay, so the artery was blocked. What was it blocked with? It's usually a pause, but the patient will usually say fat or cholesterol, okay? And since cholesterol is a lipid, they're technically correct, okay? And then I say, and where did that come from? And there's usually not so big a pause. And they say, I ate it. And I said, and then for breakfast here, did you eat the same thing that put you in this situation? And then I start the discussion. After the patient connects those 4 dots and they realize that they got there because of what they've eaten, I have an opportunity to change their diet. I say, okay, so we're going to tell you, we're going to order a plant-based meal for you. You know, if you are really dedicated to helping our revenue here at Rush Cardiology, you can go ahead and order whatever you want, but we're going to recommend plant-based nutrition to our financial detriment.
Okay.
Usually,
may I add a couple of things here? Because I am enjoying our interview so much, I feel like I'm talking to myself in the mirror. The way I put it is that the food service deserves a kickback from the surgery department and the pharmacologic department of each and every hospital, because they promote the disease that brought the people there in the first place.
That's right.
In other words, it's a mutually advantageous situation to serve the same foods that brought you there. At a teaching moment, by the way, when the person is having a heart attack, which brings me to a second problem I just ran into that I want to share with you personally, that we have discussed, and I know you have something to add to it. Yesterday, I went to Salem, Oregon, for a bill proposed locally that we would serve as an option vegan meals in our hospitals and prisons and nursing homes. And the people supporting it thought it was a no-brainer. But I told them, I only found out about it the day before, so I had no time to help prepare them. All I did was go and give a testimony. But I told them the way they were going to beat you is they're going to come in with their dietitians, their hospital representatives, and they're going to say, we already do this. There's no need to implement any other rules. And you have had a similar experience, I know, of the frustration of the obvious being denied by the establishment, who happen to themselves be vestedly interested personally and also financially in continuing the status quo. Please comment.
So one of the things I learned in leadership, Dr. McDougall, is it's often quoted, it didn't originate with me, but that old line about never attribute to malice what is easily attributed to ignorance. Okay. And so I don't think that our dietitians are, or the pharmacy, they're not interested in creating revenue. They're not thinking through the process. How do I know that? Because the leading cause of death in those people is heart disease. If they knew what you and I know, of course they would promote it for their patients. And I need to add very quickly that the same thing is true in cardiology. That is, the leading death of cardiologists is still heart disease. Now that may sound like the most strange irony to ever happen, but it's absolutely true. And so, a good friend of mine recently was president of the American Heart Association, and very famously, you saw the write-ups where he had a heart attack right there during the American Heart Association meeting. I know what it is to stand in front of that, 5,000 people as president and try to deliver a speech that motivates them, and the stress that goes with it. And rupturing a plaque during that is actually a reasonable thing to do. Let's not have the plaque in the first place. And so if I really could impact this field before I'm, retired, it would be to change the nutritional education system so that every cardiologist knew exactly that the disease that they're treating and working so hard to try to stop people from dying from is actually generated by things that they can control. And they need to fix it themselves, their family, their colleagues, their neighborhoods. And if we become the source of health in the cardiovascular world, then it's going to leave the country. Right now, it's not infectious disease anymore. That's the number one cause of death around the world. It's heart disease. And a lot of it has to do with the exportation of our culture to third world countries and other developed countries. And so are we going to take responsibility for that and change it? The last thing I would say is I actually, because of my there was so much going on in the nuclear cardiology world in terms of expenditures and appropriate use, totally different topic. But it got me elected or appointed to the Medicare advisory panel for payment. And that's called the HOPS, the Hospital Outpatient Prospective Payment System. And for 4 years, I went to Medicare 3 times a year. And I sat and listened to them. I learned so much. And one of the things that I learned is that they're incredible people. They're really, really smart, and they really have a tough job covering Americans who are bent on ruining their own health and yet surviving the ruining. So that, what does that do to the Medicare? The best thing you could do for Medicare financially is to pay your way, work, pay your way, and then have sudden cardiac death at age 65. That financially is to the benefit of everyone else. But people are not doing that. Our sudden death rate is going down while the disease rate is going up. And therefore, Medicare is overwhelmed. So the trustees say that in 2026, that the Medicare Trust Fund will be bankrupt. That is not sustainable. So I would say that, yeah, we could spend all this money on healthcare instead of roads, bridges, and free education for every inner city child. We could do a lot of things with the money that we're doing that we're spending on healthcare unnecessarily. So now I'm telling everybody, it's not just cardiologists, that it's your patriotic duty as an American to change your diet, to change your lifestyle.
Yeah, I tell you, you remind me of myself, except you're still in control. I've lost that. Anyway, let's get on to something else. I want to take you in another direction. You gave me the introduction. I think this allows me to do this, and that is, you mentioned your beginnings were in Medscape. You talk about scientific research and the importance of scientific research. I happen to be reading a few articles on Medscape about you, and one of the questions you were asked during one of your interviews was about research and publications. So you said, again, this is not a direct quote probably, but it's close enough. You said, I think a landmark publication was the Courage Study. When you and I met the first time about a decade ago, in addition to our alliance in terms of good diet and how we should be fundamentally dealing with heart disease from the cause, I ask you, and I ask you as a challenging question. I'm going to ask you again today as a challenging question because you were the past president of the American College of Cardiology. In 2007, the American College of Cardiology, along with the American Heart Association, told cardiologists to stop doing heart surgery on people with chronic coronary artery disease. Yet, follow-up research papers done on whether or not our colleagues changed their behavior and practice showed they made absolutely no change, even though your organization and the Heart Association told these business people, these cardiologists, to stop doing the surgery, which in my opinion, looking at what the surgery has done, we're talking about 80-90% of the surgeries performed today. You guys told them to stop in 2007, and it's now 2019. You do the math. What's going on? Tell us about the Courage Study and the OAT Study and the other studies that show the benefits of doing surgery on chronic coronary artery disease. Please.
Okay, so let me just add one to that, and that would be the FAME trial. If you take OAT, FAME, and Courage together, it really did challenge a lot of the things that people were doing. So OAT, for those who have not seen it, it was the open artery trial where we used to say that, open artery is better than a closed artery, and therefore you should expend, all of your wires and to take what we call total chronic occlusion, take an artery that's been blocked for a while and try to open it up, because bringing blood flow, what we used to say, if you're hurting for blood flow, that's so-called ischemia, that ischemic blood heart cells want blood, not drugs. Well, it turns out the OAT trial didn't support that at all, that if an artery was blocked and had been there for a while, that opening that artery did not improve outcomes, even though it did improve blood flow. So that was number one, the first challenge. The next one was absolutely the Courage trial. Now, was heavily criticized because it was highly selected population. That is, you could just imagine you're going to do something that's so against the way the community practice is. You're nervous as a cardiologist that if you have a bad outcome, that things are not going to go well for you in our courts. And so it's difficult to study some things, and that did happen. I mean, the amount of, you may remember the numbers, but it was something around 10% of the people who were eligible, who were approached about the study, actually participated. And so that is the first criticism by everyone who does invasive cardiology, that this was a highly selected population. Well, be that as it may, there was an advantage to revascularization. It was that the people would have chest pain go away significantly faster if you open the artery, whether it was bypass surgery or stenting. The problem is you have to ask yourself, is 6 weeks versus improving the diet, and this was not the optimum diet, it was just better diet, okay? And the better diet was on both sides of the trial, by the way. Is that 6 weeks worth the expense that we're doing and the rehab time if it's open heart surgery? And most people would say that it probably isn't. And that's why it changed the guidelines to say only take the people who have critical ischemia, that is poor blood flow to the heart, and the people who are having a heart attack. That's a completely different situation. Sure. We have such wonderful data that if you open up arteries during a heart attack, you actually improve the outcomes, that I don't think that'll ever be challenged. The only challenge to that would be, how do we stop people from having heart attacks in the first place? And I'm going to stick on that for the rest of my career. But I would say that the COURAGE trial did give us the insight that if you're willing to make some changes, go on medication, do an exercise program, and put up with the fact that you're going to have some chest discomfort longer than you would if you had a stent put in your artery, that you're going to have a good outcome. Now, the FAME trial was really important because for those of us in the nuclear cardiology area, people would say, oh, I had a stress test and it was a false positive. Well, it turns out that the blood flow is way more important than the amount of narrowing. That is, what's the impact of the narrowing or of the disease? Not just, oh, you have a 50% narrowing here. Oh, no, that one looks like 70. Well, it depends on who's reading it. And the fact of the matter is, if you measure the flow with a flow wire, you will actually get something that correlates with outcomes so much better. And so that was telling us that we do not need to do as many stents, and we should actually do more flow wires. And I think that one has caught on, that people may not be doing the diet and the exercise the way COURAGE meant, but the FAME really has changed the field. We may be doing a lot of revascularization these days, but we're not doing as many as we could be because we're putting that wire down, measuring, said, that looks like 70% narrowed, but the flow is perfect. So I'm going to leave it alone. And so wouldn't it be great to partner that data with, and because we know that with high-dose statin, plant-based diet, and an exercise program, I have a little acronym I came up with a few weeks ago, and I'm trying to save everyone. SAVE standing for statin, aspirin, vegan diet, and exercise. Okay. And so if we do that, we know that the plaque is going to regress. So I'm not worried about a 70% becoming 80, 90 and totally occluded. I know that it's going to get better. So it's from here, if we change everything about what made this happen in the first place. So I think we have gotten to the point where there's more of a recognition of that. Let me say one more controversial thing, and I hope the invasive community is aware of it in the big universities, maybe not so much in the community places, but that what the American College of Cardiology, American Heart Association were trying to do with appropriate use criteria is to try to optimize, do the right thing for the right patient at the right time. That was our slogan. And the fact of the matter is, if you have left main disease, you're going to benefit from revascularization. Now, you might want to take a chance and do plant-based nutrition. You're taking a little bit of chance. Nobody's ever done just that, completely plant-based nutrition. The next one is the so-called widowmaker, the proximal left anterior descending, those words meaning the top of the artery, the beginning of the artery that goes down the front of the heart. putting a stent in there or even a single vessel bypass has been shown to improve outcomes. The challenge that I have for our cardiology community is to show me where any other stent in any other location, if it wasn't during a heart attack, that's diagonal branches or the circumflex or the right, all the technical names for the arteries show, and people will say, oh, they put stents in 4 different arteries. Show me any data that those stents have improved anyone's outcome, other than left main and proximal left anterior descending.
So just to summarize, what I have been trying to get you to say, which I think you said, is that the treatment of chronic coronary artery disease, not a fresh infarct, not getting to the laboratory within 90 minutes of the event, but people who have, which is the majority of the population over the age of 30, people who have these old scars, these old plaques that they operate on commonly, most commonly, research both with bypass surgery and with angioplasty techniques has not been shown to prolong life. Is that correct?
If you exclude the left main and the proximal left anterior descending, then it's absolutely true. And that those are areas that I think still should be looked at. Okay, just because it prolongs life doesn't mean that it optimizes life if you don't do the lifestyle changes that you and I have been talking about.
All right. Well, let's talk about those again, because I think I've got you to at least, and I know you're in a very important position of trying to make everyone on all sides of the picture at all levels of knowledge to come to an understanding that's so fundamental and important for us. And your approach, I applaud, to say the least. But people should know that that there's a good chance that they're going to be treated unnecessarily when they have chronic coronary artery disease. Let's go back to your personal diet these days, Dr. Kim Williams, cardiologist, former head of the American College of Cardiology. Let's go back to your personal diet. Here you are. It's been 16 years that you've been aware of health eating, the importance. You're not taking any supplements except for some herbal preparations. Life is going well for you. You feel good. You're playing tennis. You're enjoying your family. And you have a tremendous amount of respect on both sides of the argument. And you're a key player, to say the least. What is this key player at age, let's see, you'd be about 65. What is this? Almost. Okay, you're about 8 years younger than I am. What does this key player do to get to be 72 or 82 or 92 and still be able to deliver a message that has personal as well as planetary benefits?
Well, I say the important side that I have to give kudos to Dean Ornish talking about mindfulness. Most of us in cardiology had ignored all of that. With one exception, there was a FDA-approved device about almost 20 years ago that did a biofeedback thing. You put on this strap and it controls your breathing and your blood pressure will fall 30 millimeters of mercury. So that was data a long time ago saying that mindfulness, meditation, yoga, prayer, there's great studies on all of these showing improved outcomes. And so I try to do some scripture. I try to do some yoga. It's difficult to get everything in every day. But I would say that the best formula would include something with mindfulness. The next one is exercise. And we do have recent prevention guidelines, and we are talking about trying to do 150 minutes per week of exercise. I think that that's sort of the maintenance level. The treatment level, if you've got a problem like your triglycerides, obesity, whatever, is not controlled, is to aim for the 300 minutes per week. But I do want to give kudos to all of the data that's relatively recent and that we do quote in our prevention guidelines that says, anything you do, you may not get to 150 or 300, but doing something rather than nothing actually does improve your outcome. So mindfulness and exercise. Then you've got the nutrition side of it. And yes, I am doing much more these days of a whole food, plant-based diet. I know that nuts are controversial For a lot of folks, there are people who violently say that you absolutely have to have them, and other people are just as strong saying that you shouldn't. I would love to see randomized trials, not where you're looking at substitutionary benefit. I know the Adventists say that you change your meat to nuts and you improve your outcome. That doesn't, is that because if you take cyanide and replace it with arsenic, you're going to do better? You definitely will do better, okay? But that doesn't mean that the arsenic's good for you. So it may be that nuts are still bad, but let's compare it with something other than meat, where that's just a terrible comparison. So we don't have that data, but we have people saying that, this is an absolute must, you have to do them. Well, where do I draw the line? Because they have a fair amount of fat, I tend not to give them to people who are obese. And but if you look at the data that we have, as weak as it may be, because they're observational trials rather than prospective and randomized, you do have good data that whole grains and even nuts, fruits, berries, beans, despite all of that lectin stuff that people are putting out there, do improve outcomes significantly. I probably should talk about fish for a moment, since I'm talking about our guidelines, because our guidelines do say fish. Well, that's in the recommendation. If you read the subtext, you'll see that the problem with fish is that it does increase mortality when you compare it with vegetables. But when you compare it with meat or eggs or red meat, fish is wonderful. Again, so I wouldn't say arsenic versus cyanide. I'd say lead poisoning versus arsenic versus, that is, it may not be good for you at all. I guess, I'm sorry, it was fish. I should have said mercury. Okay.
No, mercury, yeah.
Indeed. So it would be great to see more analyses or prospective randomized. We have a little bit, the Predimed trial, and I have to tell you, these wonderful, wonderful people who put that together, the Mediterranean diet prospective randomized trial showing a decrease of 30% in bad outcomes. Okay, but the problem with it is that 30% did not include a mortality benefit, and it didn't include a heart attack benefit. It only decreased stroke significantly when you did the subcategorization. Therefore, what is the big benefit of eating fish? Well, the benefit is getting rid of meat apparently decreases your stroke rate. Okay, having said that, it makes sense because, as you know from my own experience and prospective trials, changing to fish from or chicken from red meat, yeah, you're going to get a lot less colon cancer, but you are not going to lower your cholesterol. If that's what you're trying to do, you're barking up the wrong animal. And so the Predimed people did go back in a very, I think, unheralded publication. They went back and reanalyzed their data for vegetable consumption, 5 quintiles. And what they showed is that the top 2 quintiles, which would be almost purely vegan and those who were close to it, those top 2 quintiles had a dramatic mortality benefit that was missing in the rest of the trial. And so Mediterranean diet is good as long as you ditch the animals. You actually will lower your mortality. Now then people will criticize that and say, sure, it was prospective, it was randomized, but this is a post hoc analysis and therefore it doesn't count. It's only hypothesis generating. Okay, all right, so if it's hypothesis generating, let's do those studies. Because I would like to, the next time I participate in an ACC/AHA guideline and I'm pushing all of this data forward, I'd like to be able to base it on randomized trials so that the value of that recommendation does not get downgraded.
There are so many topics that we've opened up. Like, I'd love to discuss with you more about the Mediterranean diet and also more about the cardiac studies, including left main coronary artery disease, et cetera. But I think we have we've given our audience a tremendous amount of information, entertainment too, and from my perspective, Dr. Williams, I am so happy to have you not only on our team, but out there in front, fearless and willing to sacrifice pretty much everything. The difference is the attempts you're making are being well received. And I just see tremendous progress. I would like, as a final closing comment from you, and we're going to do this again if you will agree to it. As a final closing comment to you, as a vegan, progressively influencing both sides of the aisle, the vegans committed and the carnivores uncommitted, and both sides of the medical business, those who are pushing drugs, all sides, drugs, surgery, etc. You've been a huge influence. So from your perspective of seeing things change dramatically in 16 years, what do you see as far as the next 16 years in terms of acceptance of the truth? And that means the diet. And that also means the limitations of pharmacology and surgical intervention. Give me some kind of summary, as even if it's a guess, even if it's just a belief, if it's a hope.
Absolutely. So I think there has been progress. If you look at our last three, first of all, why does the American College of Cardiology, American Heart Association put on prevention guidelines? Because we really are trying to get to my goal, which is to not be number one. And I always talk about the same issue of the Spanish flu epidemic of 1918, and us not. That's the last time that heart disease wasn't the number one killer of Americans. Okay, well, what are we going to do about that? Well, prevention is seen as the key. And if we're really going to work on this, then we have to approach it from every angle: the smoking cessation, the weight reduction, treating lipids, and first and foremost, hypertension. I was very pleased to be on the hypertension writing group. I learned so much from everybody just being in the room where it happened, to quote Hamilton. And I tell you that everyone is concerned about the same issue. How can we do this without drugs? You, Dr. McDougall, you had been so proud of all the physicians sitting around the table trying to figure out how to improve blood pressure without drugs. If you look in that document, it's published in November 2017, or go online and look for the slide set, you're going to see these two slides on non-pharmacologic treatment for blood pressure. And adding up, what do you get when you do isometric exercise? And then you add dynamic exercise. And then you add resistance exercise. And then you lose 2 kilograms of weight. You cut your sodium to less than 1,500 milligrams per day. You increase your potassium. That's an easy way of saying plant-based diet. Increase your potassium to more than 3,500 milligrams per day. And you do a diet that, in the DASH diet, which is the randomized trial that was used for the basis of the recommendation, you do fresh fruits, vegetables, you're doing legumes, and low-fat dairy. And even though the DASH people actually, kind of like the Predimed people, they actually published the less low-fat dairy you do, the more the blood pressure falls. But in that trial, you had a dramatic reduction. And the impact of all those things I mentioned was about 4 to 5 millimeters of mercury. But it was additive, every single one of them, okay? And I left out the last one, which was decreasing your alcohol. If people are drinking more than 2 drinks per day as a man, more than 1 drink per day as a woman, you will get that 5 millimeters of mercury if you back off the alcohol, okay? So you add all of those things together, and the diet, that wasn't 4 to 5, that was 11 millimeters of mercury. And so you look at those two tables and you add it up, and you're talking 35, 40 millimeters of mercury that you can get off by changing your lifestyle. Who needs a drug if you can do that? And so, yes, we document, the importance of how to do management, less beta blockers, more ACE inhibitors. We go, and if you're African American, you ought to be on a diuretic unless you're controlled without it. If you're African American, you should be using a combination of drugs. We go through every single detail of how to manage blood pressure, in the hope that people will never have to, because they've done the lifestyle changes that are really necessary. So there has hope. Yes.
And your hope, your perspective as to the next 16 years. Yes. Do we have a chance?
I think we do.
Will success and the truth outpace the money? Is there any possibility?
Right. So the money is an issue. You have some people who are really dedicated, like the cigarette industry. I was going to say 20 years ago, but they're still there. The tobacco growers actually. There's a lot of interesting things going in that area, but you have people who are invested in things that generate higher cholesterol. They're not worried about the cholesterol. They are actually worried about their business. And it would be, when you hear that some of the meat companies are changing to plant-based meats, I hope that those things are healthy and that there's studies to prove that they're healthy. But again, even if, from my point of view, even if it's going from cyanide to arsenic, you're probably going to improve the outcome of the United States, and maybe you're helping us get to our goals. The next one I would mention would be people, I think, I'm not misquoting them, they're in California, they're called the reducitarians, where, I don't know if you've heard of them, they put on a conference every year. And their idea is that, oh, you vegans, you'll never get there. Let's get everyone to just decrease some. And I'm sitting there listening, and I'm realizing from a mathematical point of view, if you're trying to save the planet, save some animals, get to my goal, which is to be number 2, they're probably right. If you get everyone to do a meatless weekend, not just a meatless Monday, but a meatless weekend, the impact of that on cardiovascular health would be absolutely incredible. And so I do see hope with that. It's a completely different thing that I would ever do. I would not have, I prefer that my people have the perfect outcome, not just a reduced mortality. I want to eliminate it if I can from an unnecessary disease. But then the third one I would mention is the fact that our guidelines now that I talked about, we have to do the next step. It's not just enough to put guidelines together that say, this is what you should be eating and this is how much you should be exercising and the like. You actually have to have implementation strategies. And that means, public service announcements and doing what we're doing at Rush, which is going into churches, going into community groups, measuring risk factors and telling people you're eating the so-called Regards Southern diet, the Regards trial. Everybody's got to see the Regards group, University of Alabama. That data is absolutely incredible, and it shows that the African-American diet is the worst thing you could possibly eat that they can find. There's probably something worse, but nothing in the United States. And so let's try the implementation strategies where we spread out and really make a difference. So I don't mind talking about it because the trial is over, but one of the larger churches in Chicago, Rush University, we were able to go into the church and convince them with a lot of help from their pastorate that if you're going to give up something for Lent, let's give up animal products. Yeah. Actually fed 50 people 3 meals a day, totally vegan. And Lent is just over. And so I don't have all the data back. But the anecdotes that people, and obviously anecdotes are just that. People send you an email because they're really impressed. Does it happen for the whole group? But what I'm hearing is 20 pounds went away. My blood pressure dropped. I went to my doctor. My blood pressure was 98/50. He took me off all my drugs. Everything we're hearing is tremendous. Now, it was one Lent period. It's one city, one university, working with one church. We've got to go bigger. We've got to make that broader, and publications will help that. And then and then I'll let you go, obviously, but is randomized trials. It's very difficult to sit in that room, and I was, again, pleased to be on the prevention trial writing group for ACC-AHA. And I'm going all gung-ho, giving them all of this data, and they have the correct amount of skepticism, very frustrating, but the amount of skepticism saying that is not a randomized trial. Adventist Health, 5 different groups of people. The vegans are different. They behave differently. You can't necessarily attribute their 9.5 years longer that they live, which sounds pretty good. You can't attribute it to the diet necessarily. There's a lot of things. Well, I know what they're saying. I understand that criticism. I don't go to bars on a Saturday night and do knife and bottle fights, and I wear my seatbelt. I mean, are vegans more risk averse? Probably true. How do you get around that? Well, prospective randomized trials. And so that's what I'm imploring everyone who's in our area is not just be an evangelist, be a scientist, and let's get the research done. Prospective, randomized, large, long outcome studies, not just lipids and blood pressure and all the like, but with outcomes. And then we'll show them.
All right, but I do want to point out that none of the data on tobacco and disease is randomized controlled trials.
Correct.
All of the data is observational.
Yep.
Yet we are convinced as non-smokers that tobacco is a killer. So I disagree with you as far as us needing more studies and better studies. I think the problem is we are dealing with people who can't see over their own dinner plate. And as a result, when you go to a Heart Association meeting, I would guess still unhealthy foods are being served. When I used to go to the meetings, it was roast beef and cheesecake. I don't know that they've improved much. But I think the problem is our colleagues, most of them, and it's slowly changing, can't see beyond their own dinner plate. Just like you can't convince a smoker that cigarettes are killing them, or an alcoholic that drinking does anything but prevent heart disease. Comment.
Kyle, please let me comment on that. So first of all, if I move really close to the camera, you can still see the bruises on my head from trying to promote plant-based nutrition in the guideline writing group without randomized trials. It was very, very difficult. And so I will push back and say that, yeah, you don't need them. Then I'm convinced, and I think anyone who reads a large amount of data is convincible. But to get a guideline group to say this is, the guidelines are supposed to be how we manage everything. And they become HEDIS measures or performance measures. People are going to get paid or not paid based on this. So you have to be very circumspect and have a high bar. And that high bar was just very difficult to say that there's harm, not just for trans fats, but for added sugar and eating cholesterol at all. I mean, even though there's massive amounts of data, without prospective randomized trial, you're not going to get people to vote for it. And so you weren't really disagreeing with me saying that we don't need more data. I cleaned up that in 2003. But to get everyone on board, that's why we need the prospective randomized trials. And so I do feel that we do have an opportunity before us, that the time is right to take all of the hypothesis generating, which is it's a kind of an insulting term. This is a huge trial. It's not just hypothesis generating. It's not just descriptive. It is prescriptive. We should be doing this. It's really hard to be in that room. And so I'm thinking that that we can and we should. I would love to say that the Surgeon General, without randomized trials, went on ahead and put cigarette warning labels. That was a wonderful thing. But I think we were with enough sort of pushback from industry in that area, we are going to have to go fully armed with randomized trials. And if we don't, we'll always be subject to the criticism that it's just observational. It ain't necessarily so.
Well, the United did randomized controlled trials. The studies done on chronic heart disease surgery were randomized controlled trials. I don't see randomized controlled trials really changing any behavior. But, there are so many things we have to discuss. I want to talk to you about more about the diet, Mediterranean diet, how we get people to change, how the CAS study dealt with the survival benefits of left main coronary artery disease, anterior coronary artery disease. The CAS study needs to be a study that you and I talk about. And so there are lots of things. I think that our discussions together have been some of the most enlightening for our audience that we've ever had. And you are such a clear speaker, clear thinker. Everything you get, you deserve. And I hope the arrows don't hurt too much in your back.
Well, thanks. Thanks so much. People do respect you. And I should say, by the way, that guideline experience, I'm pretty much sure that with my presentations and of these non-randomized trials, that I heard a lot of comments from people. By the way, after I'd listened to your stuff, I changed my diet. Okay. And so, but that's not just the goal. We want everyone to change, and that's why we're pushing on it. And I know we'll get it done. I don't know how soon, but I know that you can help because you've got a big following and a lot of respect. And so hopefully, if you understood the position, it is that no, we don't need them, as you say. What we need is the buy-in, and that's the way to get them.
Yeah. Well, thank you. Thank you very much. It was great. Again, I can't think of another guest I'd like to have back more than you, because there are so many things that you and I are parallel on, including the frustration level. Again, I have 8 years on you.
Indeed.
more than 8 years, including, I mean, I've been doing this for 40 years. You've been doing it for
Fantastic.
16. So, I can't think of another guest that I'd rather have on again. And I would like to set up another date for us sometime in the future when you have time. I know your schedule is just, I don't know how you maintain a good diet, to be quite honest with you, on those airplanes and airports. But again, they're changing too. So you're doing better. Dr. Kim Williams, cardiologist, past president of the American College of Cardiology, a mover and shaker that's changing the world, changing establishment, cardiologists, physicians, and is playing a role that's paramount in what's happening in our future. Thank you very much, Dr. Kim Williams, and I wish you the best.
Thank you so much for having me. It's really, truly a pleasure. Looking forward to next time.
It will be a great time. Bye-bye.
Bye-bye.